I am thrilled to be here in the enviable position of your first speaker after lunch. So I will do my best to, if I see you nodding off, I will call on you by name. It really is an honor and a pleasure to be here for a whole bunch of different reasons, not the least of which is some of us are old enough to remember when we still did journal publishing on paper, and so to see what has happened in the entire space that we all live and work in just in a matter of a few short years is really exciting. I was happily at the first Medicine X and several of the precursor conferences, and so I want to thank Larry and the team for inviting us not only to present, but to present up here. We were at one of the kids' tables last year, and we're in the main room today, so thank you very much. I am the Director of Communications at the Patient-Centered Outcomes Research Institute, and what I'd like to do after giving you a brief overview of what we do at PCORI and why we try to do it is to bring on stage several of our partners in the world in which we operate, because I can give you some background on what it is we do and why, but I think what will be especially interesting for you is to hear from the people who are actually doing the work on the ground and why they do it. And we include within our little panel two of the patient reviewer partners who are working directly with our researchers and with our team back in Washington to really try to do research differently. That's what we talk about. So just a little bit, I know I've personally met several of our applicants who are in the room, so without having any inside track, I wish all of you the very best of luck. I have no impact on any of those decisions. I wish I did. Whether or not you're familiar with PCORI, I thought it would be helpful to just give you a little bit of a sense of why we were brought into existence. We all know that traditional research has led to tremendous advances in health and medical care, but traditional research has almost exclusively been the province of investigators scientists who come up with really interesting questions, apply for funding, get the funding, do the work, and then move on from there. Very little of the traditional research paradigm has been focused on asking and answering the questions that matter most to patients. So that is one of PCORI's core commitments, is to take a look at that. We do comparative clinical effectiveness research, and I'll tell you a little bit more about that in a second, but it's a natural to want to answer patients' questions because patients and those who care for them, family caregivers and clinicians, want to know what the right answer is to the question they might have. And patients, as we certainly have heard from this and other conferences, we know that information is power, and what more empowering than the right information that is relevant to the question you might have about the care that matters to you. PCORI was created somewhere in this big pile of papers that I think is the Affordable Care Act. We were authorized by the ACA in 2010, and just this past Monday, we celebrated our third anniversary, the third anniversary of our board being announced. And we actually have been posting a number of blogs on our website from some of our key stakeholders, including a couple of our patients who have been involved with our work, just talking a little bit about why they believe the sorts of things that we're doing could be helpful. But as you see here, the thing that makes PCORI a little bit different is that we were essentially developed to work on issues that are of concern to stakeholders across the healthcare community and the healthcare spectrum. And as I mentioned, we do comparative clinical effectiveness research. We do research that takes a look at what works and what doesn't, comparing two or more treatments or management approaches in a variety of conditions. We also, because we know that that sort of evidence, as good as it is, doesn't exist in a vacuum, we also spend a fair amount of time taking a look at how health systems work. And in a comparative effectiveness way, how can we improve the way health systems can provide care that answers the questions that are of importance to patients and those who take care of them. We really are focused, and I can't emphasize this enough, and it is an evolving process, but we really are focused on the concept of patient-centeredness. We require that all of the applicants who apply for our funding explain to us in detail how it will answer questions that are important to patients. So what do we mean by this? Here is kind of our definition, if you will, in 4 easy steps of what we mean by patient-centered outcomes research, but essentially, given my particular situation, what is it that's important to me? How can I expect the care that I am given what will happen to me as that care is delivered? What different options do I have? What are the benefits and potential risks, harms of each option? What can I do to improve the outcomes that are important to me? And perhaps most importantly, how can the clinician and the healthcare delivery system within which the clinician operates maximize my opportunities to make the best decisions that affect outcomes that I care about? We also focus a lot on what we call patient and stakeholder engagement. This is not a new concept to many of you, but we actually see it as a path to rigorous research that will answer questions that make a difference to patients. This is our little circle of life graphic that we like to use sometimes. But essentially, we emphasize in what we do back in the office, as well as what we require of our applicants, that patients and other members of the stakeholder community, community groups, caregivers and others, be part of the research team, not just be the subjects of research, but be partners in research from the very beginning, and we'll talk a little more about that in a bit. We've started to try to flesh out and fill out the mechanisms by which we try to do this work by calling on many sectors within the healthcare community to sit on advisory panels to help us refine the work that we do. So we have 4 in place now. You see them here. The members of the advisory panels look at much of the research that we are conducting and or propose to conduct, and talk to us in great detail, at great levels of sophistication, about the factors that they bring from their various constituencies and why these are issues that we should consider as we try to take a research concept all the way through to an actual funding announcement. We also have a panel on patient engagement, and that's really designed to help us always be focused on best practices in being patient-centered and engaging patients and caregivers in the work we do, as well as to try to help us educate and guide researchers and research teams in being patient-centered as they apply for our funding. We try to take this concept very seriously. We don't just require it of our applicants. We also make it as part of our review process. So even though others in healthcare have, in certain areas, engaged patients and other caregivers and stakeholders in the actual review of applications for research, we don't think that anyone has quite done it the way we are trying to do it, which is globally. So all of our applications are reviewed by panels that are comprised of scientists, patients, caregivers, and other representatives of the broad healthcare community. They all work together in the same room, at the same table, at the same time. And while they are obviously focused on issues of scientific rigor, as well as potential impact on practice, there is a great emphasis on patient engagement and patient-centeredness. Pardon me, and you're going to hear from one of our reviewers in a little bit who can take you inside the review room without giving away any private information and tell you just how that whole process works. I just wanted to impress upon you in the red type here that these are the criteria that our reviewers use to judge applications, and you can see we have 5 research priorities, and you can find out more about them on the website. But for the first 4 of them, which have to do with sort of a traditional CR, if you will, comparing various options, improving healthcare systems, addressing disparities, and how we communicate research to try to get it into practice more quickly, you can see that patient-centeredness and engagement are 2 of the criteria. In our 5th priority, which is about methods, how do we do the work we do so that the resulting evidence is reliable, is trustworthy, is actionable, and is meaningful, we emphasize patient-centeredness and patient and stakeholder engagement there as well. Very quickly, we've been around for 3 years, as I mentioned, and the first year was largely us getting up and organized. I don't know how many of you have created a National Research Institute from scratch, but I'm here to tell you it is not a picnic. It's not very easy, and it takes a little bit of time. And we have had some bumps along the way, and some people in this room have been carefully telling us about those bumps, and we appreciate that because we are nothing if not open to criticism and improvement. And I hope that we are responsive, and if we're not always as responsive as you might like, then I invite you to keep engaging with us and help us do a better job. But so far, we've committed close to $275 million for almost 200 projects. We are funding research in 36 states, including Washington, D.C., and we have committed to committing to more than $400 million in research this year. Those of you who track these things know that based on how the funding streams go, we are expected to have a total budget by the time we're done, and we are authorized to operate through 2019 of about $3.5 billion. So we are the largest nonprofit independent funder of comparative effectiveness research in the United States. Whoops, I went the wrong way, my apologies. So I invite you to get in touch with us if you have not already, to get on our mailing list, to take a look at our website. Everything we do is on the website. We try to be as transparent as possible about our processes, and I hope I will hear from many of you over time. So with that, I'd like to introduce our panelists, have them come up. Come on up. So while they're coming up and joining us, let me introduce who we have here. First up here is Diana Chingos, who is one of our reviewers and a reviewer mentor. She not only was brave enough to jump in as a reviewer of our funding applications, but she was brave enough to offer to train others in how to do it. We also have one of our pilot project researchers, Dr. Ming-Tai Seal, who is just across the street at the Palo Alto Medical Foundation Research Institute. I always have to get that right. A lot of words. Ming is one of the principal investigators on one of the early projects that we funded, which was essentially one of 50 that were designed to figure out if we're going to get into this patient-centered, patient engagement thing in a big way, how exactly might it work? So she is studying kind of the underpinnings of that. And one of the patients involved in her study, one of her partners, Sam Gordon, is here. And so what I thought we might do is, starting with Diana.
Thank you, Bill. Thank you for going patient first.
We have a slide so that you can contact Diana, but maybe that'll come up. There she is.
A little low tech, don't you think? So my background is as a breast cancer survivor. I thought I was an N of one in this room, but apparently there's somebody else here who has survived breast cancer 3 times. There you are, okay. Right, power to you. So I had a rare opportunity after my 3rd diagnosis to penetrate the walls of the academic medical center. The director of the cancer center at USC decided he wanted to bring the patient's voice to research. And his name is Peter Jones, although he's no longer the director of the cancer center. So for the last 13 years, I led a patient and family advisory council at USC, which also meant serving on the working committees. So again, for this very, very long length of time, I was able to review cancer clinical trial protocols, engage with other patients, teach them about research, also represent our patient group on the executive committee for the Cancer Center. During that time, I have to say I was very lucky also in that the breast cancer advocacy movement had launched, and there were many opportunities for me to receive training as a patient advocate. There's a course in particular called Project Lead that's offered by the National Breast Cancer Coalition, but also to serve as a consumer reviewer for the breast cancer specific programs. So it's unusual. You know, a lot of patients have a lot to say, a lot to contribute, but they're really separated out. They're really segregated from research. And likewise, for researchers who are trying to get the voice of the patient, who are trying to understand what the patient's concerns are, they really have no access to the community. You have to make a really big effort to forge these community partnerships. So when I found out about PCORI, I was absolutely delighted. This wasn't something, or this isn't something, I should say, that is cancer-specific. It involves all different disease conditions. They reach out to patient reviewers representing different stages of disease, different types of disease. They reach out to other stakeholders in healthcare, not just the traditional academic researchers who normally conduct peer reviews. So you have nurses represented, you have insurance companies, providers, you have everybody's there.
You want to maybe just spend a minute taking everybody inside the room for a review and just talk a little bit about how how you viewed that process, because you work a little bit in both worlds. You work in the advocacy world, but you also have been deeply involved with an academic medical center, so you can kind of see the different sides.
I'd be curious to know from the room how many people here have been part of peer review, of traditional peer review. So there's a good number of people here. PCORI calls it merit review. It's a little bit different. You're looking at technical merit, yes, but as Bill mentioned earlier, you're also looking for the patient-centeredness of the proposal and the extent of patient engagement. Very often we see investigators who say, I plan to make a contact with a patient advocacy organization. It's clear that patients haven't been engaged in the process from the start, and they certainly haven't helped to mold the research questions. So I'm very excited by the technology I've seen here today, and I'm hoping that after this meeting, PCORI is going to see a bump in very, very innovative technologies that have high technical merit, that are patient-centered, and that also include patient engagement from the start.
So we'll talk a little bit more in the Q&A about exactly how it goes in the room, because as you can imagine, and I've heard this personally because we've done a number of blog posts about this, there's some very interesting dynamics, and we hear quite a bit from folks who come in with one thought or another who kind of emerge a little bit different, a little bit changed by the experience. Why don't we go to two of the folks who are working on the ground to try to make a difference in the way research is done. Start with you, Ming, if you want to talk a little bit about your project and what its origins were, and then we'll let Sam talk a little bit about how he came to the project and why he thinks his expertise is important.
Sure. Do you want to? Can we go back to the other slide?
There you go.
Okay. So I hear. So some of you have seen that episode of Seinfeld, right? So Elaine.
We didn't have time to clear copyright, or we would have played the clip.
Yeah. So Elaine was labeled as a difficult patient because she had a preference of not needing to wear that paper gown, right? She had a mole on her arm that she prepared herself with wearing a shirt, sleeveless shirt. But she was labeled as a difficult patient. And she found out by accident. And then when she tried to explain to the doctor she wasn't really being difficult, she was really being viewed as really being even more difficult. So the doctor this time didn't even look at her rash, and he just left. So this is, of course, Seinfeld is comedy, but when researchers at the Palo Alto Medical Foundation Research Institute did focus groups and did surveys of patients, what they found is even among patients of the Palo Alto Medical Foundation who are well-educated, well-insured, they had the same concerns about if they were to speak up, if they have some different opinions about what's going on in that exam room, they may be labeled as a difficult patient. And if so labeled, they fear that the quality of care they receive may be negatively affected. So we want to make a change to this picture. Dr. Dominic Frosch, who led the work of the focus groups and the surveys, wrote a proposal to PCORI to wanting to propose this pilot project to how to create a zone of openness to increase patient-centered care through communication. But before he was able to actually start the project, he took a position at another organization, so he asked me to take over. So I'm the principal investigator, but we really, I had to thank Dominic for writing the proposal and to getting the funding. And we're having a lot of very insightful research, doing the research with our patient stakeholders. We have 4 patient stakeholders, 4 physician stakeholders, and 4 support staff, clinical support staff who are nurses, medical assistants, and office managers. What we're trying to do is to develop interventions that will assist this communication between the patient and physician. I have to tell you that I've been doing research on patient-physician communication for over 10 years. And some of my work evolve around studying audio or video recordings of patient-physician encounters in office visits. One of the very poignant visits I watched that took place in the Midwest, this patient came with a list. Probably many of you encourage patients to get prepared before they go to the office with a list of issues they want to address. So this patient came with a list, and they were going down the list. Initially, the doctor was very patient, and then the clock was ticking. So about 12 minutes into the visit, the patient raised her hand. She wanted to ask a question. But what happened was the doctor came over to her, and so Bill, can you raise a hand? Doctor came over and turned it into a goodbye handshake and basically escorted her out of the room. So it seems just asking the patient to be prepared with a list and raise your hand is not sufficient, right? It's not important. When the clock is ticking, the doctor has a waiting room full, something else needs to be done, right? We need to think beyond just activating the patient. How many of you use patient activation measures? Anybody? Yes, some of you do. So you want to activate patient, but that's not enough. So here in the zone of openness, in this study, we want to activate the patient, but we also want to activate the physician. We also want to intervene on the physician to coach and to help them with communication skills and provide feedback so that when the activated patient comes with a list, with a raised hand, they will actually be able to look at that patient in his or her eyes and listen and provide meaningful feedback and have a way, we're developing a tool where the conversation, the main decisions will be discussed and negotiated, and we encourage them to share in the decision making, and for the doctor to write out what did they decide to do. And we have a place to remind the patient to teach back, to repeat back to the doctor what they have decided, what would be the next steps. So these tools are, we developed them actually with support from the design and innovation team, IDEO. So many thanks to PCORI for the grant that we're able to engage with IDEO, to develop the prototypes, and we're going to be in the field soon. I have to say, this is a different experience of research. I'm a health economist. I'm trained to look at data that's collected for other purposes. Here when we work with our patient and clinician stakeholders, what we do not only came from their wisdom and their experience, but they're already using it. Like Sam was saying, I want to use this. I want to take this to my doctor's appointment tomorrow. I want to write it down, So this is, it's tremendous.
And Sam, as one of Ming's partners, can you tell us a little bit about what brought you to this work, and really, take us inside the process of being part of the team as opposed to the person that research is done on?
I'd like to split my comments into 2 areas. One is, how did I get here? How did I become part of PCORI? and then a little bit about my own experience as a patient. I'm going to guess back as an undergrad, I started doing volunteer work around Philadelphia where I was going to school, and then I moved out here in the early 60s, and I've just always been a volunteer for something while I was continuing with my career as a businessman. I was at that time, I was worried about little kids and children and their illnesses. So I was one of the founders of the Ronald McDonald House movement. We were actually the third Ronald McDonald House in the nation. Now there's quite a few around. Speeding up, I've worked in all sorts of different areas, from exercise and its impact on health, through the aging process. And in the last, I'm going to guess 4 or 5 years, I've been concerning myself with two areas of aging. One is, what do you do with old people that can't afford to live in some place? Which is to say low-income housing, and right now if anybody has a few million dollars that they can spare, I've got a really nice, clean-cut operation that could use the money. If you don't have that, I'm more specifically here, because here in Palo Alto we have an organization called Vanitas, which is a place where seniors can go and get fed, have food during the day, have care, a physician, dental, so forth and so on. Part of their work that I have been more involved in is how does one age and stay in place? What if you have a perfectly lovely, wonderful one-story home you've designed, you've had it set up for aging? What do you do? How do you go about getting qualified care? Not just driving, but we all hear lots of stories about unqualified givers that come into a home and steal people blind. This is an organization called The Villages that started back in Cambridge, Massachusetts some years ago, and it's developed quite well here in Palo Alto, and I was on the board as well of that organization. Through that specific organization, a flyer came around one day. They're running a study over at Stanford. Would you like to participate in patient advocacy? At that juncture, when I saw that paper, I was a 185-pound runner, hiker. I was more concerned with how far I could run in one day than I was with any other part of my health. Although my wife, who is present now, was more concerned about the fact that I weighed 185 pounds and should probably weigh a lot less. But the way my condition is now, she doesn't tell me to pull in my gut anymore, which is nice. Went to meetings, and then I started feeling kind of poorly. I blamed it on some of the supplements that I was taking, and that wasn't true. It turned out that Steve Jobs and I have inoperable pancreatic cancer. Don't feel sorry for me. I've led a wonderful life. It's just these are the cards that I've got to play, and I'm going to play them the best I can. So I now can come up and say, I have 3 different feet in this pool. 1, I'm a patient. 2, I'm an advocate for other patients. And 3, I know the research practices and the volunteerism. By the way, parenthetically, I know that money in every volunteer or every study is a problem. And one of the ways that you might find people on your respective boards or for respective donors is to talk to people who are already volunteering. Yes, they're busy, but for a good cause, busy people always have a little more room for another good cause. Now, what do I find being a patient? For starters, I know everything. Let's start with that basic premise. There's nobody that can tell me anything. That being said, what I'm accustomed to being is a patient that breaks his ankle a patient that, yes, doing dumb things, a patient who's got a runny nose or a fever or some silly thing, I run in, see the doc for 10, 15 minutes, and I'm out. 15 minutes is a long period for me to spend with a doctor, historically. Okay, what do I expect from a doctor in that environment? I don't really expect anything. It's like taking my car into the garage. I need to get a new oil filter. Well, I need a new prescription for a runny nose, and we're home free. That's not my story anymore. The stick I use right now, the thing you saw me walking up, that's my hiking stick. I run with that. The top comes off and I put my camera on it. It becomes a monopod. So I have to be thinking about new ways of conducting myself, new things that I'm using. But the other thing that's been a stunner, an absolute, complete different perspective that I've ever had, is the professionals that I'm working with are not quickies. They're long-term relationships. What do I find in these long-term relationships? Well, I find, especially here in Palo Alto, am I proud of being at Stanford? You bet. You bet. When I was diagnosed, we thought about going down to Houston. We thought about going back to Boston or Seattle or New York. Had a lot of pressure to go to New York. Nobody else is any better than what we've got here. They might be as good, and I'm not sure of that, but they're not better. So we stayed here. Yeah, Bill, I am prejudiced about here.
Perfectly fine.
I found really wonderful, wonderful scientists. I'm going to say that again. Wonderful, wonderful scientists. They were more than pleased to spend scientific time with me. But let me tell you, with the kind of disease, long-term disease I've got, and we all know what the outcome is going to be. There's no question about that outcome. The outcome is a given. How do we get through this outcome with scientists? And if it sounds like I'm beating a drum, I am, because the scientists are wonderful people. They know their subjects. But all you have is a hammer, everything looks like a nail. If I come in with a problem, and by the way, my main problem to date has to be with dealing with pain. Pancreatic cancer is a funny thing. I didn't know it. The biggest problem with pancreatic cancer is the pain that's ancillary to the actual disease. The oncologist is a wonderful, well-trained human being. Pain's not her big issue. So I was kind of stumbling around. And I went to a meeting that Maine was running. And we started talking about patient advocacy. What on earth is patient advocacy? I had no clue. I knew what child advocacy was. I knew what senior advocacy was, or is. But I didn't know what patient advocacy. So I was able to take some of the information that I got from the research that we were discussing at IDEO in our PCORI meetings. That wasn't published. It wasn't knowledgeable in any part of the world except me. And I was able to go to these wonderful scientists and deal with their issue. Please, I'm not saying these people aren't good docs. They are. They are taking wonderful care of me. I'm in great health. I'm not in great health. I've got great help. And I stumbled around. How many of you ever heard of I have trouble making this word.
Palliative.
Palliative medicine. That's more than I knew. You know, remember I said in part of the introduction that I know everything. I knew that that kind of meant that I had a week to go, maybe 2 weeks. If you have a long term to go, like 6 weeks, maybe you're going to go see some of the other folks. I had no idea what palliative medicine was. Incidentally, neither did my specialists. Not because they don't care, it's because it's so new and it's so important. Okay, what's the bottom line? For me, through being a partner of Ming's, and hopefully I had something to do and something to add to the research itself,
Of course.
I was able to help myself. And let me tell you, it's been a huge, huge difference. Thanks.
Thank you. Let me ask 1 or 2 questions, and then I'm not sure how much time we have. I'll go take a look, but then I'd like to be sure we open it up to the audience, because I think you have probably many folks who have questions that'll be far better than mine. But I wanted to ask Diana, just very quickly, picking up on a couple of the themes that Sam just raised. A couple of things I heard really related to the difference between the personal experience and the expertise and wisdom that comes from that, and perhaps the formal, in our case, research experience, and how one who has interests and concerns approaches a different role, trying to help those who may have traditionally been in charge of the process see the process a little bit differently. So you come to the work that you've been kind enough to do with us with personal experience as a patient, but also experience as a patient advocate working in a professional situation. So how in the course of review do you bring those different perspectives to play in a way that will not just bring your own experience, but will hopefully improve the research that you are looking at and result in work that others can do that will reflect what you hope you might do if you had the chance on your own?
Okay, so PCORI has has put together a rigorous training team for patients so that they can understand the difference between their personal experience and how to represent the broader population of patients with their condition or generally speaking. And off topic slightly, Bill, excuse me here, but I just want to say that meetings like this are interesting to me because I get inspired. I hear about this technology, the wearables, these tracking devices, and they're all outstanding. And I wish I could figure out a way to incorporate these to measure the things that I want to know. But we still have, we don't even have full implementation of health IT in this country. I mean, in some ways, we are incredibly, ahead of the curve, and we are way behind in healthcare. We have a lot of catching up to do. Likewise, the issue of pain came up, and somebody was asking, what kind of metric do you use to measure pain and compare it, whatever. I mean, in hospitals now, a lot of nurses use cards with faces on them. I mean please. So, and also to backtrack a little bit, just so everyone knows, I can describe the peer review setting for you. It's a little boring. It's a bunch of people around a table with laptops. But there's, because it's so rare for a lot of scientists to be in a room with patients scoring, giving their reviews of these proposals, scoring the proposals, really having a say. They are training not only patient reviewers and the stakeholder reviewers, but also the panel chairs so that they're aware of unintended messages they may be giving out, or allowing the scientist experts to speak longer than the patient reviewers, and just really trying to stay on task so that the whole meeting moves along, with fairness to all involved. There's also been a new change. Bill has mentioned that, PCORI has changed a few things since they started, and they continue to change, and they continue to listen. So after every review, if you have concerns, they will contact you. They set up these telephone focus groups so you can have your input, and they can tweak the process again. There was a time when you could only if you did not get funded, you could only submit a second time. They've lifted that now, so you can submit and keep taking these reviewers' comments into consideration until you have something that's really there.
Great. Well, I see by the clock we have a few minutes. I want to be sure that some folks in the audience who may have questions get a chance to ask questions of our panel, since you have some inside views of patient involvement in research and in the review process. Anybody have something they'd like to pose to our folks? Any potential reviewers or patient partners in the...
I know there's one in this room. I met them at lunchtime.
While we wait for a question to come up, I wanted to ask Ming and Sam, take us inside the project itself. How do you work with patients? How do the patients work with the investigators? You meet frequently, you go over problems, people talk about the issues that have come up in the course of the study. I'm not, I think it would be interesting to know exactly what the interactions are like, because I assume you're modeling the same behavior you're trying to study, which is a zone of openness between your partners and the investigators.
Yeah, that's really interesting. Great question. So we, according to the proposal, it was set out, we would have stakeholder meetings, periodic stakeholder meetings. We've had 3 of them so far, where the research team will work with all of the stakeholders. And we would meet in a room, smaller than this, but we have round tables. We'll have at each table at least one researcher, one patient, one physician, one nurse or MA or the office manager. And we will have these large poster boards that we use, Post-it notes, when we do brainstorming, what are the barriers, what are the facilitators to open communication, just free flow, big ideas, capturing them. And then the researchers will do iterative prototyping, and then we will involve the patient and the other stakeholders again. We give them homeworks. We don't call them homeworks, but so we don't just do things like like in medical care we have like a visit-centric health services. Nothing happens in between visits, so we have meetings, but we also have work and communication, emails or things in between meetings. And then at meetings, we'll have these round table, and then we have presentations, and we also would do role plays. Like when we had our prototype, we would have our, thankfully because our stakeholders represent various stakeholders in this process of improving communication. So we will have them role play with our prototype. Mm-hmm. So the MA will room the patient, then the patient will talk about what's on the patient's agenda to the visit, and then the MA will take our prototype we're designing. It's turning out to be a booklet. Take that to the doctor, and then the doctor will understand. Have a little conversation huddle with the MA, and then go back to the exam room to talk to the patient, and then we'll audio record the whole process, and then we listen to them, and then we glean from them what worked, what didn't work, what needs to be improved. So this is the process where we're involving our stakeholders.
I see I have a couple of people at the mics, and I wanted to try to be sure we get a question too. Dave?
Mm-hmm. Hi, Bill. Hi. As we've discussed numerous times before, I have a very different view of how much PCORI ought to be harvesting the patient perspective. Mm-hmm. The Institute of Medicine in their report a year ago said that the learning healthcare system needs to be anchored on patient needs and perspectives, mm-hmm. which means not just asking people what they think while people continue doing what they were doing. And in particular, as we've discussed, I've got concerns about the dollar value that PCORI puts on a mm-hmm. day of patients' time. Mm-hmm. Can you tell me what that is?
I'm not involved in that level of detail, so I can't, although I'd be happy to follow up with you. But the one thing I would say is that, as I mentioned early on, a lot of what we're doing is evolving, and a lot of the evolution is in direct response to concerns that many of our patient partners have raised.
Come on, Bill. That's a PR, that's a director of communications answer. You know, this is, I'm a marketing guy. I understand that. But we got to have something more than I'll be happy to follow up with you. I mean, the last I heard, it was either $100 or $200 for a day of a patient's time. And that's no way to fix the problem.
Are you
just
talking
talk to
about
that?
for reviewing?
No, I'm talking about what's the
anything.
value of what we're doing. Let me tell you
I'm
this,
sorry,
sir.
in a research study?
I think, Dave, what Dave is asking about, no, for reviews.
For reviewing, okay.
The
So that's
project-
changed, by the way.
Okay, good.
Yeah.
Good, that's,
It seemed, for me, and I'm going to argue that this is true, and I'm also been heavily involved in marketing, selling a lot of different things over the years, successfully and not so successfully. I cannot measure the dollar value of my participation as either a patient or as a researcher from the information that I've gotten. I'll be pleased to talk to you about the urges of pain that I don't have and the urges of pain that scare the daylights out of me that are coming. If you'd care to join me afterwards, I'd be pleased to, but I just don't see how we can measure right today the dollars.
that's, sure, I understand. I mean, I almost died from kidney cancer. I understand all that. My question was, out of the $5 billion, how much is going to patients versus
Well, it's not
just
as if
inviting them
patients
to
are
have a
paid a different amount
conversation?
than scientists who review. It's one standard payment for reviewers, period. But
Good. Okay.
Yeah, I mean,
Can anybody say what that is, or is it unspeakable?
well, it depends.
No,
It
it's not
depends on the-
unspeakable. It's information that I'll be happy to get for you, and I didn't bring it with me. So
Well,
Okay.
I apologize
I'll
for
let
that.
others go.
But I'll also tell you that one of the points that we've taken a look at in the review process is trying to take account of those issues and others that patients have raised and try to make the process easier for them. I think we are out of time. Can I take one more question? Or are we out of time? I see the clock is at 0.
I see, well, there's some, well,
I think we're going to
Okay.
have to wrap up, but we'll,
well, she has a question.
yeah, okay, please.
I was a PCORI reviewer in June. I'm also a patient representative trained at the FDA. I brought up both places the concern that implanted medical devices are failing at a very high rate, and there's extreme harm to patients that is not calculated into the medical community. That information has not really been responded to either by, as far as I could tell from the recent grants from PCORI. And I am concerned about the word engagement and patient engagement because I don't think there was anybody more engaged than myself. There really is no reception for engaged patients at high levels. I've been explaining to people it's like inviting yourself to a party where you're not invited to, and you already have social anxiety at the parties that you are invited to. It's very uncomfortable to do this over and over and over again, and to have the cost and the credentialing before you even get into the room. And then to keep bringing up something that's extremely substantial, the cost of these joint replacements is the #1 expenditure of Medicare and Medicaid right now. It's not a small thing that I'm bringing up.
No, I
You need
understand.
to
I would like
join
the
with a
response.
researcher and submit your proposal. You need to study this problem, obviously.
I've spent 5 years for free doing this. Thank you.
Okay. Well, I'll be happy to take other questions after the session. I want to respect everybody else's time, so please join me in thanking our panel, and be happy to talk with anyone afterwards who might like to have further conversation. Thanks very much.